Second person will be Vineeth from Medicine 4 on Breaking Bad Good News.
Good morning, everyone. I'm presenting on behalf of Medicine 4 and the presentation titled Breaking Bad Good News. So coming to our history, there's a 41-year-old housewife from Bangladesh who presented with complaints of cough for 6 months, occasional hemoptysis for the past 4 months, loss of weight of 3 kgs over the past 4 months. So the cough had minimal mucoid expectoration. There was no associated wheeze or any atopic history, no diurnal or seasonal variation, no fever, breathlessness, palpitation, chest pain or syncope, no pedal edema, no decreased urine output. And she had associated minimal streaky hemoptysis. Maybe once a month or so, she was saying she had hemoptysis. No large volumes of blood or clots were there. She also has a weight loss, an unintentional weight loss of 3 kgs over the past 4 months with no associated loss of appetite. No abdominal pain, nausea, vomiting, jaundice, or altered bowel habits. And the rest, no renal symptoms and no history of headache, blurring vision, altered sensorium, seizures, or any other complaints. The past history, she's a known hypertensive on oral medication for the past 2 years. And she has no other known comorbidities, no previous hospital admissions or surgeries. Personal history, she's a para 3, living 3, no history of any contact with animals, cattle, or pets, no recent travel history, no history of exposure to tuberculosis or any no history of any family history of malignancy, chronic illnesses, or TB. So on examination, she was alert, conscious, oriented, vitally stable. She had a BMI of 25.6, and her blood pressures were slightly on the higher side, 140 by 86 millimeters of mercury. General examination was unremarkable, and respiratory system examination was also unremarkable. The upper respiratory tract was normal. There was normal areas, no added sounds. Cardiovascular, abdominal, and CNS examination were within normal limits. So our syndrome was a lady with chronic cough with hemoptysis and weight loss, and a middle-aged lady with no clear findings on clinical examination. So before we go to the differential, just this thing about the investigations. Her hemoglobin was 13 at the time of presentation. Total counts were 7,200. Platelet counts were normal. Creatinine, liver function tests were normal. Electrolytes, calcium, phosphorus, PTA, PTT, BBVS. HbA1c was found to be high, 8.3, but her sugars were well controlled. She was a newly diagnosed diabetic. TSH was within normal limits. And this was her X-ray. So if you actually see the X-ray on the left, in 2021 in Bangladesh, this was the X-ray. And the X-ray on the right was the first X-ray taken in CMC in March 2023. Anyone want to comment on the differentials? Okay. Coming back to the presentation. Yes.
Why was the X-ray done in 2021? You said the symptoms were only for 6 months.
Yes, sir. She just had an incidental X-ray done earlier, which she brought with her. She was asymptomatic at that time. So one thing that I just wanted to comment on this X-ray is it's an enormous lesion. And then there's another lesion also on the new X-ray, which is producing very, very disproportionately less amount of findings. And history and findings are nothing at all on clinical examination. We couldn't find anything at all on the on clinical examination. I just wanted to highlight that with this X-ray. So what exactly happened to our patient in CMC? She, before coming here in December 2022, which is just around the onset of symptoms, she had an outside CT scan where they said there's a neoplasm in the left upper lobe with metastatic nodule in the right upper lobe. So then she underwent a USG guided biopsy outside, which was, we don't really have the report. There was a report on this thing saying query suggestive of adenocarcinoma. In 16th of February this year, she had actually come to a medical oncology OPD where she was planned for a CT guided biopsy of the lesion. On 20th of February, the biopsy result came as no evidence of malignancy, so she was planned for a repeat biopsy, which she underwent again, and then presented to medicine OPD on 14th for further evaluation. So this is the progression of what happened to our patient in CMC. So we actually see the biopsy report on 23rd. That also shows some focal alveolization and no signs of TB, no signs of malignancy. The repeat biopsy done on 3rd also shows no signs of TB, no signs of malignancy, and no specific features. There were occasional multinucleate giant cells. Other than that, nothing was very specific for any suspected lesion. So when she came to OPD, we had actually done a repeat set of investigations. So hemoglobin had come down from 13 to 11.6. And the only other major change was that the eosinophil count had gone up from 1 to 22. Other than that, there was no other significant difference from what she came. So just to pause for a minute, the multiple masses on X-ray, the differential diagnosis are either neoplastic, such as METs, which are the primary, the first differential you'll think of under neoplastic is metastasis, renal, GI, melanoma. Uncommon is bronchoalveolar carcinoma or lymphoma. Infections such as TB, fungal infections, septic emboli, and hydatid cyst. Inflammation such as sarcoid, rheumatoid nodules, vascular such as Rendu, Oslo malformations, and inhalational such as silicosis and ABPA. This is a pure radiological set of differentials, not a clinical one. So if we see multiple masses on X-ray, this is what we think of radiologically because we were stuck without any clear diagnosis clinically. So coming to actually Echinococcus granulosis, that was the final diagnosis of our patient. We'll come back and see how we diagnose that. As we all know, the life cycle, man is an accidental host where ingestion leads to actually this embryonated egg in the feces is ingested, then migrates through hematogenous spread, either gets deposited in the liver or the lung or many other tissue sites, and then forms a cyst over there. So man is an accidental dead-end host for this parasite. Okay, coming to how this diagnosis actually, if you see the natural history of disease, there's a very, very large subclinical phase. They may be found in any site of the body, either from primary inoculation, which is rare, or via secondary spread, which is more common, hematogenous. Most of the cases, 2/3 are in the liver, 1/4 is in the lung. The initial period is often asymptomatic because the parasite has very little host reaction to it, and it can grow to enormous sizes because the tissue that it chooses is usually elastic, like the lung. If it is in the lung, because the elasticity of the lung parenchyma can grow to very large sizes without any symptoms. And then the clinical presentation usually happens either due to mass effect within the organs or obstruction of blood or lymphatic flow that happens, or if there's a complication such as a rupture or a secondary bacterial infection. So the parasite per se can remain for a long time. If it's not causing any of these effects, can be completely asymptomatic. So we actually see the lung involvement. It can be enormously large without being symptomatic due to elasticity. And it's often detected only when the cyst ruptures. So this can bronchial tree leading to cough, chest pain, hemoptysis or emesis, or a pleural cavity involvement can cause pneumothorax, pleural effusion or empyema. And of course, secondary bacterial infection can manifest as pulmonary abscess with poorly defined. So if you actually see the size of this, there's an intra-op picture. It's a massive cyst, but hardly any symptoms. So coming to the learning points from this, what we actually wanted to emphasize is based on the radiological findings to have a strong clinical suspicion, and we can actually see which stage the cyst is in. So if it's an uncomplicated cyst, you'll either get a cyst, which is what we saw in our patient initially, a cyst with smooth walls, on cross-sectional imaging, daughter cyst and calcification. If it's ruptured and contained, you'll get air crescent sign, inverse crescent or air bubble. If it's completely ruptured, you'll get all these signs which we'll look at. And if it's infected, you can get ring enhancement, air bubble or air fluid. with associated signs of atelectasis, bronchiectasis, lymphadenopathy, pleural thickening or effusion based on whether the cyst has had complications. So if you actually see, this is another patient, this is not our patient, where it's a very, very non-specific finding. The only thing that you can see is it's a well-defined cyst with hardly any reaction in the lung tissue outside. The remaining lung parenchyma looks quite normal. So if you actually come to the first, which is a uncomplicated cyst, one of the findings can be just calcifications, or the other can be areas of hypointensity which indicate the daughter cyst. This is in an uncomplicated cyst in cross-sectional imaging. If you come, what you actually see is parts of the cyst inside rupture. So you'll get focal air shadows. That's the thing that, so if you see, this is a crescent sign. The crescent, because it points towards the lung. Without any obvious communication to the lung, there is air within the cyst cavity. The inverse crescent sign is when it's actually pointed away from the lung parenchymal tissue, pointed towards the pleural surface. Again, you get focal air shadows. And of course, the air bubble sign where it's ruptured somewhere inside the cyst with no communication at all to the outside. So all these are indicative of contained rupture. If the cyst, on the other hand, is ruptured into this, that is what we call complete rupture, then you will have multiple air shadows within the cyst with the membranes visible in between. So the first of those signs is actually called the combo sign, which we actually see multiple membranes within it. Then you have a mass within the cavity sign where most of the fluid of the cyst is escaped and you get a small mass within the cavity. The water lily sign, which is quite well known, where the cyst is actually, there is air on both sides with the cyst floating there. And you can have a complete whirl sign where multiple membranes alone are left inside. And you finally have an empty cyst sign where all the cyst contents have completely been missing. So occasionally when it ruptures into the parenchyma, you can have all the classical findings. You can have a central lobar nodular opacity forming a tree in bud appearance where it's proliferating along with this thing due to rupture of cyst contents. And consolidation also can happen around it. The last of it is associated changes depending on whether the cyst has evoked a response. So you can have, based on the size, you can have bronchiectasis, you can have mediastinal lymphadenopathy or a pleural effusion. So if you actually see the serological testing for echinococcosis, for liver, it's a lot better than for the lung. The lung, we have only 60 to 85% in the IgG ELISA and the IgE is 45 to 70%. So actually, without getting a tissue sample, it's very difficult to do these tests. And in a hydatid cyst, the dictum is do not rupture the cyst. So if you actually remember, we went through uncomplicated, we went through ruptured, contained, ruptured, complete rupture, infected and associated findings. So based on these findings, we can actually decide the treatment without actually getting. It requires a strong clinical suspicion backed by radiological findings. So if it's a less than 5 centimeter cyst, which is uncomplicated, just albendazole alone, you can treat and wait and watch. If it's more than 5 centimeter, you do percutaneous aspiration, injection and reaspiration with albendazole. Both of these are for uncomplicated cysts. If there is any complication, you actually need to do surgery and excise the cyst. Preoperative albendazole, we found guidelines between 4 and 30 days followed by surgery. Albendazole dose being 15 mg per kg in 2 divided doses up to 400 mg BD. The thing is that normally we give albendazole for deworming, it's just 2 stat doses. Here we're giving it chronically, so we need to watch for complications of hepatotoxicity and cytopenia in this patient, in our patients who we're pursuing long term. So this is the final CT of our patient, where this was the CT on which was done by us, where we finally diagnosed the hydatid cyst. Radiology had seen the multiple fluid levels. This had been biopsied twice already by the time it came. This is the MRI finding because the CT was still not very conclusive. MRI clearly shows the whirl sign. You can see so many membranes within the cyst and so many different air pockets, which are indicative of actual rupture of the cyst. So take home points about the pulmonary hydatid is that it's a very non-specific presentation findings. Many times in autopsy, they found so many cases completely asymptomatic throughout life. Classic imaging findings, they often correlate with the disease progression. So from the imaging alone, you can get an idea. And the management is albendazole and surgery is the mainstay. Do not biopsy a suspected hydatid cyst. So coming lastly to our patient, what happened is because she had been biopsied twice, the cyst had ruptured into the lung. With albendazole, her eosinophilia actually came down. She was stable at the time of discharge and planned for surgery after a long course, 3 to 6 months of albendazole therapy to prevent systemic seeding, and then they will excise the local cyst in the lung.
Why was she sent for a biopsy without looking at the CT scan of the product?
So she came with an outside biopsy report which said suspected adenocarcinoma. So from Monk, they had sent for biopsy once. That was unconclusive.
Everything is not consistent with the diagnosis of
Yes.
cancer. Symptoms, the X-ray findings are
Yes.
minimal symptoms.
Yes.
The age, imaging features.
Nothing fit in, sir. But because of that biopsy, they biopsied it twice before she came to us. No, sir, she did not. But the eosinophilia is the only thing which we noticed. She never had an anaphylaxis.
Why do you think that her eosinophilia on the first blood test didn't show?
So the first eosinophilia, the first blood test was done before the biopsies were done here. The previous biopsy was done outside almost 2 months ago, so it probably resolved by then. The second thing which we did, the blood test which we did, was post biopsy. So that's when the cyst would have ruptured, and we would have had the eosinophilia as a reaction to that.
An uncomplicated intact cyst.
Yes.
There is no host response. There's no eosinophilia.
Yes, sir. There's nothing.
And most Hydatids are asymptomatic,
Asymptomatic.
picked up incidentally on an X-ray or imaging done for some reason. And pair is only for uncomplicated hepatic hydatids.
Hepatic.
Outside the liver. Now, do you have anything in the liver?
No, sir. We've scanned extensively. No other
That's a
cysts.
good area.
Yes.
Why do you want to wait for 3 months for the surgery?
So thoracic surgery had said that they'll wait. Following the therapy only, they'll operate.
You just want to make sure that the water cysts are not violated.
Yes.
That even if there is spillage during the surgery,
Yes.
you want to leave them in the septic.
Vineeth. Next, we have Phoenicia from Medicine 3